I invite Dr. Ahmed Jazzar, who is a HOD and consultant gastroenterologist, Burjeel Hospital, Reem, Abu Dhabi. In the last 25 years of experience, he served as a transplant hepatologist in Oklahoma, later Chief of Division of the Gastroenterology in Gulf Medical Center and Sheikh Khalifa Medical City. And Dr. Jazzar is an expert in the field of gastroenterology. Dr. Jazzar, please.
Thank you, Mr. Chairman. Good morning. It's really a pleasure to be here to talk to you today about small intestinal bacterial overgrowth. I'd like to thank Dr. Yagish for inviting me to do this talk. And I'll start. The objective of the talk is definition of SIBO, discuss conditions associated with SIBO, and simplifying the diagnosis and winding up with treatment. And really, I'm going to focus about the American College of Gastroenterology recommendations. So what is the definition of SIBO? It's really clinical syndrome of GI symptoms due to presence of excessive number of bacteria within the small intestine. The North American consensus definition was based on bacterial colony count of more than 10 to the third colony forming units per ml in the duodenum or duodenum aspirate required for a diagnosis. So really, SIBO is really a disruption of the normal small bowel bacterial population, which may result in gas, bloating, flatulence, or altered bowel function, as well as, in severe cases, malabsorption. There's a wide array of effects. There's a direct injury, changes in function, sensation, gut immunology, permeability, and loss of brush border enzymes. Sorry. The clinical manifestations can vary from asymptomatic to bloating to frank malabsorption. The gut microflora, really, in health and GI disease, we know that there's the gut bacteria population is about 100 trillion. There's 500 to 1,000 different species of bacteria in the gut, and 60% of fecal biomass is from the bacteria. And these microflora exerts important effects on the structure, physiology, as well as the biochemistry, immunology, maturation of the vasculature, and gene expression. And there's a bidirectional effects on gut neuromotor function. There's also a role for these microbiota in IBD, SIBO, as well as IBS, and even diverticular disease. There are differences also in the microflora reported in IBS versus healthy controls. So looking at the normal intestinal microflora and the pH, we can see here different bacteria with different colony formingness per segment of the GI tract, whether it's in stomach, duodenum, the small bowel, as well as the colon, with the anaerobes, or the majority, being the bifidobacterium, the Bacteroides, and the eubacteria. So there's a lot of functional aspects of these bacteria in the gut. They do have a carbohydrate digestion function. They do have a fat digestion, bile acid physiology. They do have a micronutrient store effect. And really, there's degradation, fermentation of these derived small, simple carbohydrates. There's bile acid deconjugation, even affects vitamins, including vitamin K. So what are the factors that protects against the development of SIBO in patients? The pancreatic and biliary secretions, the gastric acid, mucosal immune system, as well as the MMX, the migrating motor complex, as well as the ileocecal valve, which prevents the colonic bacteria from going back into the small bowel. So what are the disorders that are commonly associated with SIBO? We know that inflammatory processes can lead to small intestinal bacterial overgrowth, such as IBD, increased intestinal permeability, like patients with IBS and cystic fibrosis, dysbiosis in patients with systemic conditions or even cirrhosis, small intestinal dysmotility for that aspect, connective tissue disease, SIBO, amyloidosis and malignancies, post-surgical interventions like the IC valve resection, radiation exposure, or even short gut syndrome, or even blind loop syndromes, and other effects like the opiate use, elderly, and malnutrition. So from a symptomatology standpoint, the most common symptom is abdominal pain, gas, bloating, as well as distension and flatulence, and diarrhea prevalent in 2/3 of patients. Patients can develop nausea, bloating is the key symptom, abdominal distension, diarrhea, and or constipation. And in extreme cases, there's weight loss, anemia, steatorrhea, and fat-soluble vitamin deficiency. The vitamin deficiencies are not common and are usually seen in patients with iatrogenic or structural abnormality of the bowel, such as in blind loop syndrome. Noting that folate level can be increased in patients with SIBO because the bacteria produces it. So what about the lab findings? Again, folate elevation, vitamin D deficiency can happen with the consumption by these anaerobes, and a malabsorption due to the competitive binding with cobalamin from bacterially generated metabolites of the cobalamin at the ilia receptor. Thiamine and nicotinamide deficiency, fat and fat-soluble vitamin deficiencies, and vitamin K itself can be elevated. What about diagnosis? Well, the gold standard is a very interventional procedure, which is the aspiration and culture. It's very difficult to perform and has sampling error and costly. We can use the CCAT, we can use the C14 xylose breath test, but the majority of us use the breath test, whether using the lactulose or the glucose. And the bottom line of this, really, the best choice of breath test remains to be determined. Regarding the aspirate, small bowel aspiration and culture, it's really an imperfect gold standard. The pros can be performed at a time endoscopy, direct assessment of SIBO, and allows identification of potential organism plus minus antibiotic sensitivity. And the cons really invasiveness, cost, time and labor, commitment, and risk of sampling error, as well as accuracy of culturing and potential for missing distal small bowel bacterial overgrowth. So moving on to the breath testing, how do we do it? The patient comes into the clinic, we give him either the lactulose or the glucose, and because of the bacterial fermentation, hydrogen or methane is produced, and this is measured by the patient's breath. So really, the methods of detection is either direct aspiration, glucose, or lactulose breath test, as I mentioned, with the levels of bacteria for the diagnosis less than 10 to the second colony-forming units is non-diagnostic, and more than 5 is diagnostic. And some studies have shown that 10 to the third colony-forming units per ml is adequate for diagnosis, especially if you do an duodenal aspirate. So looking at the Roman North American consensus regarding SIBO breath test protocols, these are the doses that we use for lactulose and glucose, and we have to have a rise of more than 20 particles per million when we're using the lactulose, and to a lesser extent, 12 to 20 particles per million when you're using the glucose. And we look at the methane rise. It's only 10 particles per million when you're using the lactulose or the glucose. And mind you, this really has low sensitivity, whether lactulose or glucose, as we can see, 42% and up to 62% with the glucose, and 42% with lactulose, but it's highly specific when it's positive. So it's an imperfect test. So when we do these breath tests, the hydrogen breath test really is indicative of SIBO, whereas the methane breath test is indicative of intestinal methanogenic overgrowth and correlated with constipation. And what is that? The methane's effect on the bowel, the methane is produced, methanogens are archaea, which are a prokaryotic organism distinct from the bacteria and eukaryocytes. So it's a third category. So Methanobrevibacter smithii is the key methanogen responsible for the breath methane production in humans, and roughly about 35% of humans possess methanogenic flora. And the methane really is associated, why is it important? Because it's associated with a slowing of the gut transit. And this meta-analysis looked at the methane, and this was associated with chronic constipation with an odds ratio of 3.5. And there's very limited treatment data using rifaximin and neomycin. So the ACG recommends testing for methane excretion. That the ACG states that we suggest testing for methane using whether glucose or lactulose breath test to diagnose the overgrowth of methane-producing organisms. Again, the intestinal methanogenic overgrowth in symptomatic patients with constipation. So mainly, it is suggested that patients with constipation or bloating to check for that in order to treat them, which helps alleviate the constipation because of the effect of these methanogenic bacteria, if you will, or archaea, on slowing the transit of the gut. So moving on to SIBO and IBS, according to the ACG and the clinical guidelines, we suggest the use of breath testing for the diagnosis of SIBO in patients with IBS. Whereas looking at the ACG IBS guideline, which is contradiction here, testing for SIBO using breath testing is not recommended. It's just a point. Both are coming from the ACG, but both have different recommendations. So looking at IBS and SIBO with the cause and effect, the IBS really patients have a higher likelihood of an abnormal aspirate or breath test than healthy volunteers. SIBO can affect a number of factors which have been linked to the pathogenesis of IBS causing or exacerbating IBS symptoms. However, it's also possible that abnormalities in motility, gut immune function, microbiome, all these issues can increase the likelihood, in IBS patients, can increase the likelihood of development of SIBO. So looking at this meta-analysis of the association between SIBO and IBS, SIBO prevalence in patients with IBS, utilizing the breath testing is about 35%, utilizing the culture, whether it's 10 to the 5th or 10 to the 3rd, if it's 10 to the 5th, it's lower at 13.9, if it's 10 to the 3rd, it's about 33.5%, so which is similar to the breath test results. And again, SIBO and IBS meta-analyses looking at all these studies, and what they found that IBS is prevalent in about 31% of patients versus control, and the odds ratio is 3.7%, with the highest prevalence of IBS diarrhea patients developing SIBO. So we can see here in the meta-analysis that there's a predilection to the development of SIBO in patients with IBS, looking at all these studies. So moving on to other clinical conditions for SIBO testing, the ACG recommends breath testing or suggests using glucose hydrogen or lactulose hydrogen breath test for patients with suspected motility disorders and for patients with previous luminal abdominal surgery, especially patients who develop a blind loop or a bypass, because that increases the risk of SIBO. So I couldn't really do this talk without the effect of PPIs on SIBO. Is there an association? Well, there is an evidence for most studies showing that an increased risk in PPI user developing SIBO, and the odds ratio is 1.7, and the odds ratio is 1.31 in high quality studies though. So it's really, if you ask any statistician, anything less than 2 is really, they don't lose sleep about that. So really the odds ratio is pretty low. So the evidence against is that the PPI is not a risk factor in 2 meta-analyses assessing SIBO and IBS, a bunch of studies, SIBO not seen by culture or DNA sequencing, and the effects of dose duration and type of PPI is unknown. So the ACG states that we suggest against the use of breath testing for the diagnosis of SIBO in asymptomatic patients on proton pump inhibitors. So this was a very interesting study, really, that looked at the clinical survey of practice patterns, unmet needs, and perception of a novel ingestible diagnostic capsule, where they sent a questionnaire for 90 gastroenterologists in academic and community hospitals, asking this one specific question with other questions, but this one specific question looked at, when working up patients for SIBO or IBS, what % of your patients receive each of the following? What do we do in our daily practice? From an academia standpoint, we see that celiac serology is being done, as well as private practice. Empiric antibiotic therapy is given to half the patients with a suspicion of SIBO or IBS. Breath test in academia is used more at 54% in comparison to the community hospital at 43%. And half of the physicians do stool pathogens. Colonoscopy is done to a lesser extent depending on the indications, and motility studies as well as small intestinal aspiration are done the least. So again, the same study asked the specific question about what are the unmet needs for diagnosing SIBO. Well, the majority of the physicians said that insufficient accuracy in the current test options, as well as a lack of clear, easy to interpret results. So what we have right now is really not very good, and we need better assessment and diagnosis of SIBO. So in their conclusion of that study, that GIs in both community and academic settings expressed a significant unmet need in SIBO diagnosis driven by breath test performance limitations, and only a small minority of GIs were performing a small bowel bacteria aspect to diagnose SIBO. And there was a perceived strength of an FDA-approved, what we call smart capsule bacterial detection system, which I will discuss later, would be improved accuracy, interpretation, and precision as compared to breath testing, with the majority of GI suggesting they would replace conventional SIBO diagnostics with such a technology. Moving on to treatment, the ACG suggests the use of antibiotics in symptomatic patients with SIBO to eradicate overgrowth and resolve symptoms. And what antibiotics do we use? The majority of us use rifaximin, which has an efficacy of 61 to 78%. We can use augmentin, we can use fluoroquinolones like ciprofloxacin or norfloxacin. We can use neomycin or even tetracycline with a high efficacy, and even Bactrim, knowing that it has a higher incidence of sensitivities of allergy. So moving on to rifaximin, with this meta-analysis that looked at a large number of patients with a variable dose between 600 to 1600 milligram a day, with a treatment duration, recommendations about 14 days, but these meta-analyses looked at duration days between 5 and 28. The overall eradication rate was about 2/3, about 70%, with minimal adverse effects, knowing that rifaximin is unabsorbable. But is that the end of the story? Not really. Breath test recurrence after treatment is high, and it's up to half of these patients after 9 months. Well, why should we bother with breath testing? Why not just treat with empiric antibiotics? I think this study looked at the same question that pops up in our mind. Why would we need the test? Well, because if we have the test and we have positive test, patients respond better. Whether using rifaximin in IBS patients, you can see if there is an abnormal lactulose breath test, the response rate is up to 60%, where if you treat it empirically, without testing, the response rate is only 26%. And on the left, looking at the colon-forming units per ml, we can see once you have a positive test, your response is higher in these patients that were treated with norfloxacin on an adrenal aspirate basis standpoint. So are there other options to reduce SIBO symptoms? Probiotics, do we use them? Do we use dietary manipulations like low FODMAP diet, gluten-free, specific carbohydrate diet, or even elemental diet? Will be an extreme. Do we have an option for fecal microbial transplant? I'll discuss these later. Can we use prokinetics, erythromycin, or procolabide, since some of the patients have slow motility? And do we use cyclical antibiotics? So what about probiotics for SIBO? Well, the bottom line really, the ACG recommends that there's lack of consistent data to support recommending specific probiotics in the treatment of small intestinal bacterial overgrowth. Moving on to the addition of probiotics to antibiotics, and that has a beneficial effect. Looking at this study that looked at metronidazole with Saccharomyces boulardii, metronidazole alone or Saccharomyces boulardii alone. So the probiotic alone does not work, but if you add them both, you have a 55% improvement in the outcome. What about dietary interventions? You can use low fiber, you can avoid alcohol sugars, avoid sweeteners like sucralose, avoid the prebiotics, the inulin, which is really the food for the bacteria, and minimize or avoid FODMAP diets, and we all use FODMAP diets for IBS symptoms, but they can improve patient symptoms with SIBO. Fecal microbial transplant in SIBO is really, again, not effective. It has been studied in patients with C. diff, and there's currently no basis for the use of fecal microbial transplant in the treatment of SIBO. So what's new in SIBO therapy or diagnostics? Well, we have a gas-detecting electronic ingestible capsule. We have a smart capsule bacterial detection system. We have a metabonomics technology. We have a microbiome profiling and gas chromatography. And I think what is closest to being approved by the FDA is this smart capsule bacterial detection system. It's like the video capsule where patient swallows it and it detects when it reaches the jejunum and opens up and takes a part of the bacteria in the jejunum and somehow fluorescently assesses the count of the bacteria and sends it to the app that the physician has. This is really AI in practice, and if we get this, this will be the best. And obviously, the expense is very important in that aspect. What about future directions in SIBO? The use of AI to improve diagnostics, as we talked about this smart capsule, development of improved aspiration techniques in SIBO, improved breath testing techniques and advancement in testing of intestinal gases in SIBO from various systemic conditions, and prevention of SIBO recurrence is important, as well as cyclical use of antibiotics for SIBO recurrence. So in conclusion, this is really the AGA best practice advice from a symptomatology standpoint. We know it's gas and bloating, the signs, malabsorption in severe cases, the causes of SIBO needs to be considered, and a good rule is to consider SIBO anytime there is a small intestinal stasis, there is evidence of SIBO being present in a subset of IBS patients. The diagnosis, as we talked about, the culture is considered the gold standard, with new guidance suggesting a cutoff of 10 to the third, more than 10 to the third colony-forming units per ml in duodenal aspirates, and breath testing is most commonly used to diagnose SIBO and appears to identify subjects likely to respond to treatment. And therapy with antibiotics are currently the mainstay of treatment, and methane on breath testing is defined differently and now termed intestinal methanogen overgrowth. Oops, sorry about that. Thank you for your attention.
On time.
Thank you, Dr. Jazzar, for an excellent review on SIBO. Any question? Single question is accepted. We are running already late on time.
Just one comment, Dr. Jazzar. I think Dr. Azam Qayas started something now, and to start about our microbiome in the area. At the same time, we don't have data about our carrier rate for some of the bacteria, especially C. diff. Did anybody start from all these institutions to study this? No one. Thank you.
Dr. Jazzar, excellent presentation. Like in your practice, do you use combination of antibiotic plus probiotic for SIBO alleviation? And if you use, do you use do you keep a gap, because sometimes it might be counterproductive if we are giving antibiotic plus probiotic together, or if you are using the probiotic, is it something like Saccharomyces which you use because it's a yeast?
So according to the guidelines, there is no indication to do the probiotics. If you have clearly a patient with SIBO, then I would just use antibiotics alone without the probiotics. Now, if they had a recurrence or did not have a complete response, then I would add the probiotics to it. Okay? And we have a wide array of antibiotics that works very nicely in these cases. Obviously, if somebody responded completely and had a recurrence, you can use the same antibiotics. But somebody had a partial response or didn't respond, and you have a documented SIBO, then you have to switch antibiotics.
Or you change the antibiotic. And what is the gap you use? Like after one course, cyclical, how long after you repeat it actually?
Right. So if somebody responded to one and had a recurrence, then I may use the same one. If somebody had either a partial response or has not responded, I definitely would change antibiotics. Now, regarding the retesting, I would definitely wait 1 month before I redo the breath test to see if they have responded or not, or if I'm dealing with something else. Obviously, if somebody hasn't responded at all, you can switch antibiotics, but if they have still no response, then there's something else they're dealing with rather than just SIBO that's causing the problem.
Okay, thank you.
Thank you very much. We thank all the speakers in the morning session. And over to Dr. Yogesh.